we have many accounts that say, you know, I'm waiting for this toric ICL. Now, let's keep in mind that we only have 1% of the actual laser vision correction market, so there's a lot of candidates out there. What a lot of our representatives are doing is saying, hey doctor, wait just a minute. You're doing 400 LASIK procedures a year. Large corporations, TLC, LCA, they're telling us they're turning away anywhere from 15 to 20% of those people. What are you doing, doctor? Not you in particular, but doctor, what are you doing to go back and harvest, so to speak, or farm what you've already got? And I think to a degree you've done that. Can you share with us how you've gone back and done the farming in a new account?
Right. Well, you know, in our practice, when I showed up in Utah, I found that about 20% of our patients coming in for a LASIK evaluation were disqualified. They weren't
20%.
good. 20%. They weren't good candidates. Thin corneas, abnormal pachymetry, or abnormal topography rather, being the most common reasons. So the first thing I did was go back and look and see which of those patients could qualify for an ICL procedure. The majority of them actually could. And I went back over about a year to a year and a half. We started sending out patient notices, making phone calls and things like this.
Excuse me, this is actually you. You went and pulled the records?
Yeah,
You asked them, you got the records?
I had them pulled for me. And so as I'm going through the charts, in some cases the comment was made in the chart, wait for ICL. And in many cases, actually this is interesting, in many cases wait for toric ICL. But one of the things that we've learned over the years while we're waiting for the toric is how to handle cylinder from a corneal standpoint with LRIs and on-axis incisions and things of this sort. So realistically, I'd say out of 100 patients that were told to wait for the toric ICL, I can very, very realistically take care of 90 to 95% of those patients with an on-axis incision and a matching LRI when indicated. It's a very small number of patients now that I find really do qualify to wait for the toric. When the toric is approved, I'm still going to take those other patients that I'm doing LRIs on and present them the option of the toric ICL. But it's amazing, you can still do excellent results. Case in point, I just had a patient a month ago that came in for her 1-month post-op visit. She was a -16 with -5 diopters of corneal cylinder starting out. Best corrected vision was 20/50, 20/60. She is now 20/30 unaided, having performed a flap first, ICL with LRI, all of those done on the same day, by the way. I perform a femtosecond laser flap, and then ICL with LRI. The LRI is to debulk the cylinder and get it reduced as much as possible. And then a couple, 3 weeks later, to have her completion of the LASIK as a bioptics approach. There's a number of things like this that we can do with those patients. And anybody else would say, gosh, let's wait for the toric ICL, and it still is going to be an option that I'll present patients like that. But I'm not boxed into a corner even on those patients with that much corneal cylinder, or refractive cylinder, I should say.
Interesting. So at this point in time, you've been in your new practice for approximately 9-10 months?
Since July, so yeah, going on. Going on that.
So do you feel like you've already gone back and harvested what you can over the past year and a half?
I would say so. I still have some patients that have not been quick to respond to our notifying them that they're that they can come in. So I'm still seeing maybe a couple, 3 patients a month off of that initial list, but the majority of them are done. I think we're also reaching that critical mass where there's more buzz in the community. There's more patients who know other patients who didn't qualify for LASIK, and they're now being told, hey, come in and have something, have something done. Have a look at this.
Gotcha.
The other thing I did also, Don, is I actually presented a patient seminar about ICLs.
That's going back to the old LASIK days,
As a matter of fact, one of my partners and I, he presented LASIK and I presented ICL. Out of that seminar, there were 70 patients in attendance. We had planned for 70. It was basically a full house. Out of those 70 patients, I had 3 that actually came in and had ICL surgery just from that.
Yeah, just from that. Interesting. Yeah, I was up in Illinois a couple weeks ago with Phil Heflin and Brittany Dyer, one of our star performers up there. She's actually working with Dr. Swale, and I believe it's once every 6 months. They actually have a theater-type sign, kind of like, hey, come see the movie King Kong or whatever, but it's actually coming to see about refractive options. And it's a page out of the past, but if done correctly, you'll have 20, 30 prospective patients show up, and they get educated on it. And even if they decide not to have the procedure, they at least have the knowledge to go forward and tell others in the community, hey, maybe you don't need LASIK. Maybe what you need is an ICL.
Right, right.
Yeah, they know the place to send you.
An important point to make too that maybe should be shared with a lot of the surgeons out there is that if you don't offer ICLs, you're never going to know which patients prefer that as a refractive option. I didn't until I started offering ICL as an option. There are so many patients out there who have things such as laser phobias, who knows somebody who ended up with dry eyes and they're afraid to end up with the same. They've basically decided they're not going to have any refractive procedure based on a laser. You'll never get a picture of that until you actually start talking about ICLs. The one group of such patients that I have seen more of happens to be in the optometric field. Optometrists, even those who refer patients in for LASIK, are many times waiting for something better to come along, and especially in Arizona. I mean, it became the norm for us to have an optometrist come in for ICL surgery after we presented to a group of optometrists the certification seminar. And these are good, well-referring, LASIK co-managing optometrists that when they see ICL, finally the light bulb goes off and they say, okay, I can have this done. They themselves have been reluctant to have LASIK, and yet not anywhere near the same type of reluctance for ICL surgery.
Gotcha. One of the questions our representatives get is, hey, if I get more involved with ICLs, does that mean I'm going to be spending more time on complications? Am I going to have to spend more time in explaining what's going on here in order for this option to become more of a daily offering?
No, absolutely not. In fact, one of the things that I've also heard patients start to tell me now as they've become better educated about ICL is that it's less complicated than LASIK. If you think about just the circumferential incision on LASIK, it's about 2.4 centimeters, and we're dealing with a 2.9 millimeter incision with ICL. So patients are smart. The patients that come in looking for the best vision post-refractive surgery, they know where to find the information, and they get these things. So thankfully, the complications that we see with ICL, in my experience, are nowhere near the same types or levels of things that we see with, with LASIK or with PRK. Plus, if you compare treatment of a complication with an ICL, it's much, much easier as compared to a LASIK patient. Now, one of the concerns of surgeons is what if your complication turns out in the form of a cataract? Well, I have a discussion with my patients ahead of time, and I tell them cataract is something you're all going to get. All of us get it. As a high myope in particular, you have a higher incidence of cataract formation, so that you may develop one next month not having any surgery at all. It's one of the things that we'll see. However, if you get a cataract following ICL surgery, the correction for it, the treatment of that complication is completely easy, and you don't end up with any visual compromise, short of perhaps a loss of accommodative effect. But patients, even those very few patients that I've taken care of that have developed cataract, I think I have a 0.2% rate of cataract formation following ICL surgery in over 2,000 cases. Even those patients that did develop cataract are amongst the happiest ones that I've got in the whole practice. Right. They're not dealing with visual compromise. On the other hand, if you take care of a LASIK or a PRK complication, many times you do come to a point where there's nothing else to offer, there's nothing else to recommend, and they may have lost one or two or more lines of vision, and you're boxed in at that point to say, we really shouldn't do anymore. We really shouldn't do anymore for your flap stria, or if you're one of the unfortunate patients who developed a corneal ulcer and you have a scar or things of the sort. It's a very different world dealing with a complication from a corneal refractive procedure versus a implantable contact lens point of view. Extremely different.
Right. Now, Dr. Rivera, you do a lot of global travels for a variety of companies, and I think you just came back from Abu Dhabi this past week.
Abu Dhabi it was, yes.
Now, just out of curiosity, if you were to take away the innovativeness, the new technologies within the ICL category that they have, if you were to take that away, still it's been very popular for them. Why would you think that ICLs, the growth rate outside the U.S., has been double to triple to what it is in the United States? Again, take out the improvements in product technologies.
Well, the Middle East, for example, where I just came from, they have a high incidence of irregular topographies, keratoconus, form fruste, and this sort of thing. So that really is a procedure that treats those patients marvelously well. And it can do the same in the U.S. as more and more patients, and importantly, more and more surgeons realize that this is an indication for this. In the Middle East, patients are also driven by quality of vision. They also want to get the best vision correction that there is. And so I don't think, it's going to be too long before we hope to have the same levels of growth in our country, in the U.S. 35%, last year alone in the Middle East, 54% growth in ICL volume. When we get to that level here in the U.S., you're going to see more practices embracing the technology, as has occurred internationally. Those European practices, for example, where ICLs have become mature within their practices, they report a 20 to 30% penetration of ICL. We got to that in my Arizona practice, 20 to 30%. Right now in my Utah practice, the latest statistics have shown it's about 11%, but that's within 6 months. That's huge.
It's incredible.
As the surgeons really embrace what it takes to become comfortable with the procedure, become confident in their presentation, and really just love the results that they get, I do believe that you're going to see the volume grow even in the United States. The toric ICL is going to have something to do with that, but I believe it's going to take more surgeons becoming committed, and that's where it's up to the sales force to go out and really educate the surgeons that this is not just an option, but it is a beautiful option for patients' vision.
Great. One last question for you. One of our initiatives as of our global sales meeting in January was to go out and actually do surveys on what we would consider key opportunities. And as a part of these surveys, we'd be able to determine accounts that are willing, able, capable to go forward and really embrace the ICL message as well as the total refractive offering. What would you recommend to our territory representatives out there? What do they need to do after they've identified these people to become part of Staar University, which, by the way, has 4 very nice modules right now. We're getting ready to add 2 or 3 more.
Yes,
how you answer the phone, follow-up, the communication, the conversion. But what would you suggest, and once we pick out those key accounts, as far as really getting them to embrace this? Practices are very busy. It's hard to get their attention. What do you think would really send the message loud and clear that, hey, we need to listen to these Staar people, because it's not only the ICL, it's refractive.
Exactly. That's it right there. It's not just the ICL. It is what Staar is going to do to help the overall refractive practice and the refractive volume. There's no doubt that more satisfied, more happy patients within the practice are going to generate more word-of-mouth referrals. ICL patients are so over-the-top happy and so very satisfied with their vision that I found they are truly like Amway salesmen for your practice. They will practically corner you to tell you what their ICL experience has been. The more of those patients are in a practice, the more the LASIK volume is going to grow also. Because patients, they don't know the difference between ICL and LASIK. They just know that somebody had a great result. If it happens to be an implantable contact lens, so much the better for Staar. But Staar's message really has to be helping grow the overall refractive volume within a practice. ICL helps you accomplish that. It helps you rescue those patients that don't have any other options, but it also helps you push the bar. It helps you raise the bar and allow an even greater level of visual satisfaction and higher levels of outcome in those patients, even the more demanding ones, the engineers, the people who really just, they've got to be able to have the absolute best vision with the least complications possible to their vision afterwards. ICL totally helps you grow that within your practice. And if Staar can really emphasize the fact that it's about refractive volume, ICL happens to get you to that next level of your refractive volume, I think that's what will help surgeons recognize that, the importance of it.
That's great. Dr. Rivera, thank you very much for your time.
Thank you.
Enjoy the rest of your time here in Aspen.
Absolutely, it's a pleasure.
And again, thank you for your support for Staar and the insights that you've provided us.
It's my pleasure, Don. Thank you.
Ladies and gentlemen out there in the field, I hope you'll take the time not only to see this once, but maybe twice, review it, and take notes. Take sharp notes here with the highlights that Dr. Rivera has provided. Our goal, again, is to spend more time with those accounts that have been proctored, they've been trained, but they're just sitting on the edge there, trying to figure out what the right move is to embrace this technology called ICLs into their total practice. So good luck, good selling. Look forward to seeing you real soon. Thank you.